Dr. Rabins graduated from the University of Tulane, School of Medicine, and also School of Public Health. He has been on the faculty of Johns Hopkins since 1978, where he founded the Division of Geriatric Psychiatry. He has published on such topics as Alzheimer's disease, bipolar disorder, schizophrenia in the elderly, and particularly the mental services for older adults in urban public housing. A unifying theme in his work has been the crossover of neurology and psychiatry. So help me welcome this very special person to Nashville again.
Thanks, Dr. Garrett, and I also wanted to thank Dr. Mouton and Dr. Powers and their whole wonderful staffs for re-inviting me, even though I'm not a native Nashvilleian. This title, Inside the Alzheimer Mind, actually was suggested by the team that invited me. And it's not a phrase that I've used before, but in fact, excuse me, I really like it because I'm going to try to talk about three different things. One of which is that I think if we can think a little bit about what might the person with a dementia be experiencing, we might then be able to use our common sense to solve some of the problems that are occurring. I am going to talk specifically about some principles of treatment, both medication and non-medication, and then finish up talking a little bit about some of the research I've gotten interested in more recently that relates perhaps to prevention in a secondary way. This is my disclosure. And let me start with the definition. By the way, one of the things that's very impressive to me today is what a mix of different professionals there are. You know, most meetings they're either physicians and no other professions, or mostly nurses, or perhaps non-physicians. But it's quite impressive what a range of professions there are today. And I think that's what, to me, that's what has made geriatrics the most interesting field. You cannot be, quote, just a social worker or just a doctor. If you're a physician and you're not interested in the social aspects of your patient, you're not going to get them better. And if you're a social worker and you're not interested in dementia, you're not going to be able to serve the elderly. And so to me, that's what is so exciting about geriatrics. And I think a lot of that does come together in understanding dementia. Now, for most lay people, the whole concept of what's Alzheimer's and what's dementia is very confusing. And it's interesting, Dr. Blazer was on the DSM-5 committee, and at the end was chair of it, I think, and to try to come up with new criteria, and I think they have clearly improved the criteria from DSM-4. And one of the issues they raised is whether we should rename dementia as neurocognitive disorder. And I think part of the basis of that, as I understand it, is that there's a real stigma to the term dementia. The irony is, from my perspective, seeing a lot of patients, the stigma word actually is Alzheimer's disease for some reason. And so most people would rather say, my loved one has dementia rather than Alzheimer's disease. So we have a lot of work to do here. But I think it's useful to keep these two concepts, dementia and the specific diseases, distinct conceptually. So dementia, from my point of view, has a very simple definition. First, it consists of the development of two, at a minimum, cognitive impairments that result in functional impairment. So it's not only memory, and I think we have to help people realize that, in fact, memory is often, even though it's devastating in these diseases, often a minimal source of the disability that people have. So it's at least the development of 2 cognitive impairments in adulthood and a normal level of consciousness. So the normal level of consciousness, that means it's not delirium, as Dr. Blazer talked about. So again, here's a very simple definition: the development of 2 or more cognitive impairments in adulthood without impairment in consciousness. Very broad. And in fact, if we go out in the community and do epidemiologic studies, this dementia, this very broad syndrome, is primarily a disorder of the elderly. Below age 65, it's very uncommon. Excuse me. I'm sorry. But you can see that clearly with age it increases, and we've known now for a long time that this increase continues up to age 90. It's been somewhat questionable what happens after age 90. In the Framingham study, the number keeps going up, but in several other studies, in fact, it seemed to level off. But clearly, here is a disorder that is in some way intimately linked to aging, and even more striking is what's called the incidence rate. I'm sorry about that. It's the number of new cases per year is the incidence rate. And this is what's really striking. At age 65, the incidence rate is about 0.25%. So what that means is that if you take 250 people at age 65, one of them will develop dementia. But that rate doubles every 5 years. Right? If only our bank accounts would do this, we'd be great. Here it's not good. So 1/4, 1/2, 1, 2% at age 80. So if you think of President Reagan as the paradigmatic case of Alzheimer's disease, he was diagnosed at 81. But if you take 100 80-year-olds, in the next year, 2 of them will develop dementia. And as you can see, that number keeps going up. And we now have 2 studies to show that, in fact, that annual incidence rate keeps going up at least to 100. Now, the ranges are broad, but at 95, about 15% of people per year will develop dementia, and at age 100, it's around 30%. So of centenarians, about 1 in 3 is likely to develop dementia. So here's a mystery. Why is this so intimately linked to aging? We have absolutely no idea. But from a public health point of view, and realizing that life expectancy has gone up 2.5 years every decade now for 1.5 centuries, if that continues, and my guess is in spite of the obesity epidemic, there's always some reason that it won't, that if life expectancy now for the average woman in the United States is almost 80, that means in 10 years it's going to be 82.5 or 83, right at the point where this curve is so steep. So the absolute number of people with dementia is going to continue to rise in our lifetime unless we come up with some way to stop or prevent the disease. Now, not in the definition of dementia is the fact that if you ask family members what kinds of problems are you having, they'll give you a long list. And this is really to impress you with how long the list is more than the specifics. But they will not only say, my loved one is having a problem with memory or having trouble feeding himself, but they'll say, he's suspicious, he can't sleep at night, he's restless, hitting people. So the list is very long. This is not in the definition, and that's appropriate, I believe, but these are the day-to-day problems that many people with dementia are facing. Now, one of the problems with studies like this is one I did in the beginning of my career, is that these are people usually who are coming to Alzheimer's centers. And there's been a question about, does this really reflect what's happening in the disease? One of the ways to answer this is to look at what are epidemiologic studies, and I've had the privilege of being sort of indirectly involved in a large study called the Cache County study that was partly started by colleagues of Dr. Blazer's at Duke, Kathy Wells-Bomert, John Breitner, who came to Hopkins, is now in Montreal, and people at Utah State University. So This is Utah. Cache County is way up on the northern border there. And in 1996, when the study was started, Cache County had the longest mean life expectancy of any county in the United States, about 4 years higher than the U.S. average. So for studying aging and dementia, it was an ideal population. And amazingly, they were able to enroll 90% of the 65 or older individuals in that county. So pretty impressive for any kind of representative study. And one of the things they looked at was, in the people with dementia living at home, how prevalent are these neuropsychiatric behavioral symptoms? And you can see that in the past 2 weeks of the exam, about 25% of people with dementia, that's the light blue bar, were described by their family as having agitation. 25%. Whereas in the non-demented, the darker blue bar is very rare. So restlessness, delusions, 20%, and hallucinations, 15%. So these very severe neuropsychiatric symptoms are very common in all these diseases that cause dementia. Now, it turns out that there are at least 80 conditions that fall under that umbrella of dementia or neurocognitive disorder. So it's a very broad umbrella. And when I talk with patients or talk to the public and they say, well, I don't quite get this definition, but I tell people it's a little bit like heart failure. The heart can fail for many reasons, and the doctor's first job is to figure out, is there a valve problem, a muscle problem, the surrounding tissue, the liver? There are many causes of heart failure. And here there are many causes of dementia or brain failure. There are only really 4 or 5 common ones. So Alzheimer's disease accounts for about 2/3 of dementia. The other numbers, there's more argument about, but vascular dementia is probably 10%, and the combination of vascular dementia and Alzheimer's disease is also 10%. Now, that's interesting that those two numbers are the same, because by coincidence, if one disease is 60% and the other is 10%, you would multiply those together to get what's the likelihood that the two would occur together. Clearly, vascular dementia and Alzheimer's disease occur together much more than by chance, suggesting that perhaps vascular disease is in fact one of the causes or a trigger in some way of Alzheimer's disease, but that's just a supposition. Dementia with Lewy bodies had an interesting history. It wasn't described until the late 1980s, and for a time people were saying it accounts for 20% of dementia. I think it's become clear that those numbers were way too high, and it's being diagnosed much less than it used to, and particularly because of autopsy studies now, it's probably really fewer than 10% of cases, whereas frontotemporal dementia, which is generally said to be a dementia that occurs earlier in life, often in 50s and 60s, and affects about 5% of people. My guess is we're going to learn as we do more and more autopsies of very old people that, in fact, this is much more common, perhaps 10%. And if you go into long-term care and look at the people with the most severe behavior problems, frontotemporal dementia is way overrepresented, because involvement of the frontal lobes often leads to disinhibited, socially destructive behavior, and those patients often cannot be managed at home. Okay. So if you put Parkinson's disease on this list with dementia, that would be 2 or 3%. So there are really only 5 common causes of dementia, but again, there are about 80 or more diseases overall. Okay. So then, what is Alzheimer's disease? And again, this is my idiosyncratic definition. I think there are really 3 elements to the definition. First, it's a dementia that is slowly progressive. And even today, the average person comes to clinical attention after they've been symptomatic, in retrospect, for 2 years. So even though we've been talking about this for a long time, but the history, and I want to again emphasize what Dr. Blazer said, in geriatrics, taking a history is the key to making most diagnoses, and particularly here. So you have a gradual onset and progression of symptoms, almost always for more than a year, but on average now 2 years. The second step is the exclusion step. You have to exclude the other 79 causes of dementia. So the reason we do blood work, brain scans, the whole medical workup, look carefully at what drugs people are taking, is to make sure that people don't have the 1 or 2% causes of reversible dementia, and they still do turn up very occasionally, so we can't neglect that. But to let people know that it is still ultimately a clinical diagnosis. So we exclude everything else by doing lab work, a neurological and physical exam, and assessing for depression. And then the third step is the inclusion step, and this is, again, sort of my sifting things down, that people, in order to have a diagnosis of Alzheimer's disease, I believe, you have to have impairment in memory plus one other aspect of cognition. Now, I will tell you the newest criteria for Alzheimer's disease don't require memory impairment. And the reason is because 5 to 10% of people who have autopsy-proven Alzheimer's disease begin with either language problems or perception problems. But 90% have memory problems. And I think it's a mistake to change criteria to deal with the exceptions. Then you never get anywhere, as far as I'm concerned. They're going to be much less specific, is my prediction. So I think I require that someone have impairment in the ability to learn new information, and then one of these other aspects of cognition that I'll go over in a bit of detail: aphasia, apraxia, agnosia, or executive function impairment. So what does this mean? And again, I want to go over this because I believe, and I couldn't prove this, that this is the basis of our treatment, and it gets back to that title, that if we can understand what the symptoms that people are experiencing, we can start to use our common sense to solve them. So it surprises most people to learn that Alzheimer's disease causes aphasia. Right? Everyone knows, most lay people have known someone who's had a stroke and is aphasic. And in fact, in Alzheimer's disease, you see the very same kinds of language disorders. People either cannot express themselves or they cannot comprehend what's being said. And like in stroke, it's usually some mixture of both expression and comprehension. So if you can read this, this is an example of a writing sample of a patient that I saw earlier in my career. On the mini-mental, I said, I'd like you to write a sentence. And so this is what she wrote. You are required to place a big time. Now, this is the way the interview was going. This woman's husband had died a month before, and she actually was brought to me by her children because they were concerned about depression. She wasn't taking care of the house. She'd started losing weight. She wasn't cooking. And no matter what they tried to do to motivate her to do those things, she just wasn't doing them. So I have her come into my office, and I start asking her questions. And she's answering me like this, she's giving me answers that seem almost nonsensical. So of course I do what you always do when someone doesn't understand. I raise my voice and ask the question louder, which is the most ridiculous, embarrassing thing you can do. But I realized pretty quickly that she had a fluent aphasia. Right? There's a lot of words, but little content. And what was happening was, the children were talking to her, asking her to do things, but they had not noticed, because this had come on so gradually, that she had this severe fluent aphasia. And so patients with Alzheimer's disease have these same kinds of language problems, and it's a source of a lot of communication impairment. Again, patients develop apraxias. Why do people become functionally impaired in Alzheimer's disease? Why can't they dress, bathe, feed themselves, use eating utensils? Those are all apraxias, a fancy medical neurologic term, meaning your strength is intact, but you cannot carry out a learned motor activity. And if you look at the functional impairments in Alzheimer's disease, they almost all are abilities, functions that we all learn between ages 2 and 6. So again, the example I like to use is the use of eating utensils. think of children or grandchildren. How did they learn to feed themselves? Okay? They start with a spoon when they're in a year and a half or 2 years of age. It takes 6 months before it goes, down the esophagus rather than the face. Then they progress to a knife. It's at least a fork, and it's at least 6 months to get the pea on the fork. Then they learn to use a knife when they're 4, 5, 6 usually. People with Alzheimer's disease lose all these abilities in the opposite direction in general. So again, why is that useful? So again, when I'm talking to the public, the example I use is someone who's starting to have trouble cutting their food. What's the intervention? Well, if you're having chicken or meatloaf or steak, whatever, for dinner, if you cut up that food in the kitchen and only give them a fork and a spoon at their place, they're 100% functional because they can still use that fork so they're able to feed themselves. So by understanding it's the knife that's impaired, it's not that they can't eat anymore, they can't use a knife, that you've made a very effective intervention. And the second part of that, why do you do it in the kitchen? Because that preserves the person's dignity. The difference between the 3-year-old and the adult is, if I were to come up to any adult and say, let me cut your steak for you, you look tired, you would be insulted, whereas a child isn't. So I try to, again, use this as a good example for families. Say, we have these two goals, maximize function and preserve dignity. And in problem solving, it's using that over and over and over again. So again, I'm trying to use specific examples or trying to elicit from them what's wrong with the person they're caring for, and hoping that that will generalize. And then there's the perception, recognition problem, agnosia, which means the inability to recognize or perceive. And again, I think most people don't realize that one of the major impairments in Alzheimer's disease is the impairment of visual agnosia, an inability to correctly visually observe the environment. Not because the eyes aren't working, because the brain cannot interpret what it's seeing. So this is why people don't know their family members. Say, you're not my wife, you're not my daughter, this isn't my house. And either they've lived there for 40 years, or they're in a long-term care facility and they say, just take me home, I just want to go home. And almost always when they're taken home, not only does it not work, it's bad because then they're being lied to. They say, this isn't my house. And why? Because they cannot perceive the familiar. Now again, how do we know this isn't just a failure in memory rather than perception? The intriguing thing is many people are still able, particularly if they've lived somewhere for a long time, to describe their living room, for example, or the front of their house. So they can say, I have a green couch, and there's a picture of a mountain over the couch, and a red lamp, and a bookshelf in the corner, and of course you can point it out to them, and they will say, I know my house, and this isn't it. So they've not just lost, though, the ability to perceive the familiar. What that, I think, means experientially for the demented person, and of course I'm guessing here, that means they can never be in a familiar place. Right? Never. And imagine never being able to feel at home. And I think, and this again is a guess, but I think it helps people empathize. I believe one of the reasons people are so restless, why wandering is so common, either at home or in a facility, is people, they can never feel comfortable because, and again, my example is you go on vacation, after a week or two you come home and you open the front door. It physically feels good to be home. It's not just, man, I'm sick of driving or whatever, but it feels good to be in a familiar place. And people with Alzheimer's disease are often robbed of that. So again, trying to make this sort of understandable, I think sometimes helps. The other thing I try to point out to families is, like any disease, there is a kind of general pattern to Alzheimer's disease. And of course, with every disease, there are many exceptions. But usually during in Alzheimer's, the average patient lives about 10 years if you try to identify the earliest symptoms. And you can kind of break the disease into 3 3-year periods in a very rough way. During the first 3 years, it is the memory impairment, the amnesia, that is the primary source of functional impairment. So during the first couple of years, people need reminders. And I think this goes back to why is it that we still don't recognize this disease for 2 years? I think it's because most people are in a prosthetic environment. They have a spouse, a partner. They're living with other people who can say, we're going to a wedding this weekend. You have a doctor's appointment on Monday. That's the new information they need to know. But they're able to recall enough from their remote memory to be relatively functional. But in the middle 3 years, this is when these aphasias, apraxia, and agnosias develop. So it's in the middle 3 years where people don't pay their taxes, get lost driving, start having trouble cooking and house cleaning. By the way, Dr. Alzheimer's original patient, the 3 presenting symptoms were not doing housework, not cooking, and accusing her husband of having an affair. That's why she presented. So she, like most people, presented sort of in the middle stage here, but she was 51, so very young. It's only in the last 3 years of the disease that physical impairments come to the fore. So it's in the last 3 years of the disease when incontinence develops, falls become frequent, people may eventually become bedbound and mute. So people with very advanced disease. And at this point, by the way, all the dementias look the same. And I don't think there's any reason to even think that differentiation is important later on in the illness. So I think this is somewhat useful, though, in helping people plan. If I'm taking care of a couple where the well spouse is 75 and becoming a little frail, and I think someone's in this sort of middle stage, I'm going to be saying to them, you know, your husband's going to be developing physical problems soon that I think will be beyond your ability to help him. And we need to now be thinking of how are you going to get help, either in the house or you need to move before it becomes a crisis. So again, I think this has some prognostic utility, although again, it's just a very rough guide. Okay. So again, just to sort of repeat these points, again, I think the amnesia or memory loss of people with Alzheimer's disease helps explain the fact that they often lack insight. They don't know they have the disorder, and about 2/3 of people with Alzheimer's disease never acknowledge they have a problem. And in my clinical experience, even when they say, well, you know, my memory's not so good, they do not appreciate the severity of it. And I think this is, in a way, it's an agnosia of memory impairment. But some of the behaviors, I think, come from this. But I think a lot of the miscommunication that seems to be occurring is that family members don't recognize that they're communication problems, so they're talking to the person in a way that they really can no longer understand it. And so, again, when I observe that, I say, you know what speech therapists teach stroke patients? Talk in very short sentences, repeat what you want to say, and use nonverbal communication. I always use the same example so I can remember it, is, you know, instead of saying, oh, it's 11:30, let's go have lunch, a lot of words, but socially appropriate, you need to say, let's eat, I'm hungry. Aphasic patients are much more likely to understand that kind of communication. If you go up to them and sort of touch them on the elbow a little bit and scoot them in the direction of the table, that's a way of non-verbally communicating. So it does help, I believe, to recognize that there are communication problems. And I think also to tell people, if someone has one of these agnosias, the inability to recognize the environment, telling them, but you've lived here for 40 years. Of course I'm your husband. Not only is that not going to get anywhere, but they think you're lying to them because they know this isn't their house. So you need to deal with that by changing the subject or asking them what was the favorite thing about the house. Distraction is here. So again, I try to use these examples in teaching people. So that's sort of the background. How about treatment then of both patients and caregivers? Well, I think everyone knows there are 2 drug categories, the cholinesterase inhibitors and drugs that decrease GABA, NMDA, excitotoxicity, Namenda. So I'm not going to go over that, but I think the outstanding question for a decade has been, how long should people stay in these drugs? And I think we now have kind of, at least an informed way to answer that question. This is a study done by Robert Howard. It's a study from Europe, in which they took people who had been on a combination of donepezil, that's Aricept, and Namenda for at least a year. And on average, people had been on the two drugs for 2 years. Right? And they randomized them to one of four groups. A quarter of the people continued on two drugs, a quarter stayed only on Aricept plus placebo, a quarter on Namenda plus placebo, and one group got two placebos, so they were on nothing. And I think, again, this is not the easiest thing to read here. On the left is cognition, and on the right is function. So going up, this is a mini-mental-like scale. Going up, having a higher score is better. So the bottom line there, that's clearly different. That's the people on no active drug. The other three clusters are the people who were on either one or both drugs. And the results are really the same whether you look at cognition or function. People who continued on donepezil answered about 1.9 more mini-mental questions over a year later than people on nothing. People on Namenda, whether they took it alone or with Aricept, no added benefit. And I believe that there now, and I know that there are a couple new studies that suggest that Namenda is minimally, I'll be nice here, minimally effective. Okay. So again, this doesn't answer the question, but I think it helps families make the informed decision. The drug, even after a year or two, has a modest benefit. But usually when I say, well, the person on average can answer 2 more questions on a memory test, you say, boy, that's very modest, Dr. Rabins. I'm glad when they say that and not me. And some people choose to continue it, and I think some people realize that it's a modest benefit. Namenda, which has now gone off patent, so Forrest has chosen not to make it anymore because they have come out with a longer half-life form of it, which they're going to charge it's going to cost $300 a month for Namenda. By the way, the New York Attorney General is suing them for restraint of trade. It's interesting. So we'll see how that turns out. But the economics, now, it's gone from $160 or so a month to $300 a month with a very modest benefit. So I think this helps people make decisions. And how about neuroleptics for behavior? And all the drugs are pretty similar. Some might be a little better than other, but all the data look kind of like this. This happens to be risperidone. So going down here is good, fewer behavior problems. The top line is the placebo, and the bottom lines are different doses of risperidone. And these drugs are, for psychosis and agitation, very modestly better. And in fact, about 19% better than placebo. That's a very modest effect size, if you will. Okay. And this is a little hard to read, I'm sorry. This is what's called a forest plot. So you start at 0, which is no risk. And this is looking, what is the risk of dying if, compared to placebo, if you're placed on an antipsychotic drug? And I don't know if you can see it, but every drug is to the right of 0. And in fact, all the neuroleptics are about the same, except for Haldol. They all increase the risk of dying, both at 12 weeks and 1 year, by 60%. Haldol increases the risk of dying by 100% at 12 weeks and a year. Again, this is relative. But still, for very modest benefit, there's a very serious risk here. So I don't think this means you never use these drugs, but there's been a real concerted effort by CMS, Medicare, to decrease antipsychotic use in nursing homes. It's amazingly effective. This is hard to believe. They met their goal. Last year, they lowered nationally the rate of use of antipsychotics by 15%. In nursing homes across the country. Actually, Tennessee had one of the better rates, so congratulations. and they're going to try to decrease it another 15%. There's going to be tremendous pressure on all long-term care facilities to decrease the use of these drugs. And it's partly, I think it's reasonable based on this. So we really need then to buff up our skills on non-pharmacologic treatments. And I think there are just some general principles that I sort of try to identify precipitants, try to be realistic about what the person can do. And there are a number of studies that have looked at this. And Henry Brodati, who's an Australian psychiatrist, has done a very nice meta-analysis looking at all the treatment, the non-pharmacologic treatment trials, and all the caregiver studies. And the results are pretty impressive. I hope you can read it, but it turns out that for the non-drug treatments of behavioral problems in Alzheimer's disease, the effect size is as good or better than it is for cholinesterase inhibitors, number one. And number two, for caregivers, it's actually pretty strong effect size for, if you look at caregiver emotional well-being. So it's reasonable that what did they review? And the range is amazing. Some of these studies were skill training. Some were education, activity planning, environmental design, enhancing caregiver support, self-care support for caregivers, and then, of course, miscellaneous. So in a sense, I think many different things can be done to help both behaviorally and help caregivers. And they're more effective than drugs. So I think it's very clear now that before turning to antipsychotics, which still have a role to play when somebody is severely physically aggressive and somebody might be hurt, we need to be really focused on these non-pharmacologic approaches. And that wasn't supposed to be a subliminal. So this is purely my thing here. But again, I believe it's common sense. And the biggest challenge, and I think what I try to train caregivers, whether they're family members or professionals, is to describe the problem in detail. So what I say to people is if someone comes in and says, my father's being violent, that really provides almost no information to me. I don't know if they're yelling, hitting, throwing things. Right? But if they tell me every time we take him into the bathroom to shower, he pushes us away, there's a lot of information there. And so, and believe it or not, this is what Aristotle said is in a good story, and I think it relates to this. If we can get people to tell us where do these things happen, exactly what are they, who's around, why is it even important? Many people with dementia have visual hallucinations. They rarely cause distress. So to put somebody like that on an antipsychotic it's clearly inappropriate. Now, if the person's upset by it, there might be things that we can do to distract them. So I think there are a variety of general things that we should be helping people learn to manage these symptoms. And I think what that meta-analysis suggests is that they work. And I think that's impressive. Okay. Let's just skip this, just to sort of go over that. Now, I wanted to talk about a couple other things that I think are not talked about quite as much. One relates to end-of-life care, and this is something that a few years ago I was involved in research-wise. We identified 125 people who met hospice criteria for dementia. And most people don't know, Medicare has different criteria for hospice for dementia than any other disease. And if you boil it down, it essentially means they're losing weight and not eating and can't ambulate safely. That's kind of the bottom line. It's a GDS-based criteria. Nobody pays attention to it, but that's the Medicare rule. So we identified 125 people with dementia who all met those criteria, examined them every 3 months until they died or occasionally moved away. And I just wanted to go over two of the findings because I think this should affect how we care for people. 72 people that we had at least 2 different assessments on died in the study. And we were very focused on how do families make decisions about care. That was the main purpose of our study. So of the people who died, we then could look back and because we'd been examining them every 3 months and asking them, what medical decisions did you face? These are the percentages, at least in our sample. of the kinds of medical decisions that families were presented with. A little hard to read, I'm sorry. But blood tests, 40%. Okay. X-rays, 30%. Now, feeding tubes, it's a little hard to see there, 35% of our sample. For the first time, when the person was already meeting hospice criteria, the issue of placing a feeding tube was raised. That seems, whether you believe they should or shouldn't is one question. But to raise it at the time when, usually when the person's been hospitalized and it's time to be discharged and they realize they're not eating, that's not the time to raise that very difficult question. 5%, the question of surgery came up, and it's amazing, 24%, the question of placing somebody on a ventilator came up. Now again, I'm not saying that's whether that should or shouldn't be done, but people are very ill. Families are being presented with really major interventions. And I think if we're following people long term, we should be discussing these with them way before it's time for hospice care. But the other thing we looked at was how hard did family members find these decisions? And so again, they were rating this every 3 months, and then we also interviewed them once after the person died. And it's a little complicated, but we broke all the decisions into whether the family said, yes, do it, or no, don't do it. Whatever it was, whether it was blood work or surgery. And when families decided, yes, do it, do whatever it is, they almost always said that's not a hard decision. And most of the time they were very satisfied with it. But when they decided not to do something, again, whether it was blood work or send somebody to the emergency department, they were much more likely to find that a hard decision and to be less satisfied with it. And interestingly enough, having an advance directive made no difference for any of these except the feeding tube decision. Families did find that that helped them make that decision. But none, even if someone said, I don't want to be placed on a ventilator, and the family still was approached to do that, when people in our society say no, we don't think Dad would have wanted that, or given his situation, it's very hard for them. So what I draw from this is we still have a job here as professionals, and that's to understand that any of these decisions in which care is limited are really hard for families. And I think our supporting them through that, saying, I know this is hard for you. Hopefully, you don't have, occasionally it's an emergency decision, perhaps like a ventilator, but a lot of these decisions can wait a day or two. Or you need to talk to your brothers and sisters about this, and I know this is hard. I think that can be a really powerful intervention. Again, I don't have that data to say that. But I think knowing that in our culture it's hard to say no, even with an advance directive, to me, again, I think that's important. Okay, and then just to finish, how about the future? Well, I think the future for Alzheimer's disease has to be prevention, because by the time people become symptomatic, brain damage is very extensive. We may be able to stop the disease in its tracks, and I guess for people with mild disease, that will be a no-brainer. But what are we going to do with people that are in the moderate or severe states? Are we going to deprive them of the treatment because they're so impaired, or are we going to just say, no, we're going to stop the disease? I think that's a challenge. If it comes up, that's a challenging question. But there's sort of public health people for a long time have broken prevention into primary, meaning it never happens, secondary, meaning you recognize it early and maximize benefit by decreasing morbidity, or tertiary, which is just the best care. So if you were a drug company and were thinking about this, you'd probably say, well, what's going on in the brain? And Alzheimer's disease is characterized by two abnormalities that are in the middle of these slides: plaques, which are a protein called amyloid, and tangles, which are these intracellular dark staining things. This is the neuropathology of Alzheimer's disease, and we know that they indicate two different proteins, beta amyloid for the plaques and tau for the tangles. And so a number of drugs have been developed to try to get rid of these. Now, amyloid and tau are normal proteins. We all have them. Amyloid is the beta amyloid is in the membrane of every neuron. So it's a normal protein. And it turns out that in people with Alzheimer's disease, this protein is being deposited in the brain in an insoluble form 15 to 20 years before the disease. So if somebody develops Alzheimer's disease at 70, they have been accumulating the the amyloid protein since age 50 or 55. So if we're really thinking about prevention, we're going to have a way to identify people way back at the beginning. And one of the exciting developments in the last 2 years is there are now 2 imaging agents that can identify amyloid in the brain, and I think we'll know over the next few years whether people who have that early on go on to develop Alzheimer's disease, and maybe this will even become a diagnostic tool, although I think that's still an open question. How about non-drug treatments? Well, I think a very nice meta-analysis by Barnes and Yaffe was done in which they looked at all the potentially modifiable risk factors for Alzheimer's disease. And the 7 are listed on the left there. And in the box there is the attributable risk, meaning how much of Alzheimer's disease is attributable to diabetes? About 3.3%. How much to physical inactivity? This is in the United States. The biggest number, 21%. Now, they made one mistake. 54% combined is they shouldn't have done that because these things are related to each other. But if you recalculate it, you find that about a third, perhaps 40% of Alzheimer's disease at least is related to these risk factors. Of course, this is epidemiologic association, so it doesn't prove that if we could intervene on these, we would really decrease the incidence, the development. But look at the diabetes, midlife, high blood pressure, midlife, obesity, smoking, and physical inactivity. Those are, if you will, environmental, they're medical, but those are things we should be doing a better job of intervening now. And maybe perhaps we can decrease the incidence or at least delay it. So in 2 minutes, I wanted to finish up on sort of the 2 things that I've been kind of thinking about lately. One is, what if we could come up with something that slowed progression? A, is that something we should do? There's an ethical question. But B, what might they be? And second, what if we just delayed onset? About 15 years ago, Ron Brookmeyer and Claudia Kawas did these modeling studies in which they showed that if you delay Alzheimer's disease onset by 5 years, you decrease the number of cases by 50%, right? Because you die of something else. It's competing mortality there. Well, Cache County actually offers a nice way to look at this because not only did they identify everybody with dementia, but they identified a number of people who were normal with in-depth cognitive function testing and followed them over time. Right? So I was interested in looking at those people and what factors might be associated with first, how rapidly the disease progresses, since people were being examined every 2 years. I can see this is impossible to read, but turns out that having a neuropsychiatric symptom, so there's a test called the MPH, predicts faster decline in Alzheimer's disease. Now again, that doesn't prove that intervening would slow the disease down, but we now have looked in press, and this will be coming out in the next few months in the American Journal of Psychiatry, which neuropsychiatric symptom or symptoms is associated with a more rapid decline. And it turns out that whether you look, particularly if you look at progression to severe dementia, that it's agitation of all the different kinds of behavioral problems. The one symptom that predicts a more rapid decline is agitation. Now again, I don't know cause and effect here. It may be that agitation is a marker for more severe Alzheimer's. But it's at least conceivable that if we could find either non-pharmacologic or pharmacologic ways of greatly diminishing that agitation, restlessness, anxiety, whatever you want to call it, in Alzheimer patients, we might be able to slow down disease progression. And I would at least say that certainly for the first 2 stages of the disease, that's a desirable finding. So that's catch kind of. The other thing is, we were thinking, what if we took those criteria that Barnes and Yaffe identified? Now, the study started at age 65, but what if we looked at age of onset of Alzheimer's disease after 65 related to these risk factors? Because what if we could start intervening at 65? Might we delay onset? And we found, yes, ApoE predicts age of onset. Turns out that the one of those factors that the Barnes and Yaffe identified, people who exercised more when they were identified as normal and then went on to develop Alzheimer's disease developed the disease later than people who didn't exercise at all. And I'll just show you the pictures and then stop. And it turns out it's true for men or women. So people who are sedentary develop after age 65, develop Alzheimer's disease 2 years sooner than people who are active at all or have moderate activity. And again, it's true for men and women. So delaying Alzheimer's disease by 2 years, that's pretty powerful. Now again, this doesn't prove that it's effect. It could be that people exercise more because they don't have early Alzheimer's. Those plaques and tangles are being deposited in their brain, and maybe that's why they're not exercising. So I don't think we can know that, but I'm sure every single one of you, no matter what your profession, you have been asked, what can I do to reasonably think about preventing Alzheimer's? And I think that we can say there is, at least the evidence supports the idea that moderate activity, so what the CDC recommends for heart and stroke protection, 30 minutes, 5 days a week, is associated with a delay of onset of Alzheimer's by 2 years. So again, this is the best we can say at this point. It's not proof. But I think that, just to finish up here, sort of my 3 takeaway points. First, I think that as knowledgeable professionals, as knowing about the symptoms of these diseases can help us diminish the challenges of caregiving. And I think that's simple and practical in a way. But we also know how to improve caregiver well-being, and I think that's very crucial to what we all do. And again, I think even in advanced dementia, choosing not to treat is very hard for people. And knowing that as professionals, I think can inform us to be empathic and help people make these really tough decisions. So 2 minutes for questions. Sorry to go on so long. Thanks for listening.
All right, we have just a couple minutes for questions.
Okay, so 2 questions. I know this will be more than 2 minutes. The first question is the question about genetics, and I'm afraid it's a 10-minute answer, but I'll try to really shrink it down. First, we know that there are 3 what are called autosomal dominant genes, meaning if you have that gene, you will get the disease that cause Alzheimer's disease. They explain about 2%, people argue about the number, of cases. And so very rare forms, these are usually people who get it under age 60. And half of people in each generation will get it. So we already know there are 3 causes of it because there are 3 different genes, all of which seem to affect the amyloid protein and the production or the inability to remove the most toxic aspect of it. So that leaves 98% of people. Then there's a gene called the ApoE gene that was discovered at Duke. And this particular gene, which is a normal gene, and remember, we all get a copy from our mom and our dad, so we all have this ApoE gene that is involved in cholesterol transport, makes a protein that transport cholesterol in the blood. And this gene comes in 3 forms called 2, 3, and 4. Now, again, normal variants. If you inherit the 4 form of this gene, your risk of getting Alzheimer's disease is tripled. Right? So how does this work out with those numbers I mentioned before? So if you take age 80, and let's just say, be conservative, and you have a 20% chance of having Alzheimer's at age 80. If you have no 4 gene, your chances are actually about 15% of having Alzheimer's. If you have a 4 gene, your chances of having Alzheimer's at 80 are 30%. So this is the new genetics, and we don't quite know, A, how to use this information, and this is for every common disease. Diabetes, Parkinson's disease, depression, all have this complicated a number of genes are involved, and they're not totally determinative. So this is the new medicine. We're going to have to figure it out. It may be that if we figure out what does the 4 gene do that the 2 and 3 alleles don't, that might lead to a treatment. And the best guess right now, the data suggests that also the 4 has to, and the 2, which is somewhat protective, they affect how the amyloid can be removed from the brain. So it adds to that theory, although it doesn't prove it. But you can see that kind of, what does it really matter to know whether you're 15 or 30%? I think when you present it that way, most people say, that's a pretty small difference. What it says to me is every single one of us in this room is at significant risk of getting Alzheimer's disease. We're a healthy group. We're going to live as a group our mean, way beyond 80. So we probably all have 30% risk here. And whatever you're going to do to, not have children or retire early or go back to smoking, which is the only thing patients ever say, I guess you should do it. Then I guess let me quickly say about feeding tubes. The Supreme Court has opined that feeding tubes are a medical treatment like any other treatment. They're like antibiotics, and people can choose that. And I know it's a very wise group of people, but that's stupid. Feeding is a very powerful way that we relate with each other, right? And that's part of when you think about how we relate to infants and young children, so much of it is through feeding, that all through, across the age span, I believe, it has a very powerful emotional and ethical weight to it that many other medical treatments don't. So I'm not saying people should or shouldn't, but I think we need to recognize that's why it's a particularly challenging decision, number one. And number two, there's tremendous variation by region and ethnic background. So the South and African Americans are much more likely to choose to have a feeding tube placed than other groups in the United States. So this doesn't tell you anything about right or wrong, but I think it tells me this is an ethical, moral question, way beyond whatever the legal elements are. Your specific question is, and it's a hard one, are people uncomfortable if they're not eating, so they're starving to death, and that's the only way to say it, I believe, at the end of these diseases? And how do you answer that? I think there are only 2 ways. The first is there are people who come into emergency departments severely dehydrated for some reason. They're not demented, and they get their fluids and they recover. And if you talk to them and ask them, what was that like? They almost never remember. They're usually, I think, either very severely delirious, number one. And number two, when your BUN is 60 or 80, I don't know, in some way that's numbing or something. But people who survive and are cognitively normal, in my experience, rarely say, I was so hungry, or it was a terrible experience. So I don't, whether it's painful or not to have dementia and not eat, I don't know for sure, but I think there's a good chance that it's not uncomfortable. The second thing is in dementia, it develops very gradually. And it's really, I've gone through this with a lot of people. And it's totally not what I thought would happen. If you're lying in bed not moving, which is true of most people who have this problem, you're expending about 600 calories a day, 500 or 600. Your machinery isn't working very hard, and it's air conditioned or whatever. You're not sweating. So dehydration develops very gradually here. People do not look uncomfortable, whether they are or not. They don't look agitated or restless. So I personally, I don't think it's myself that it's a comfort measure the way, say, using opiates might be. I think, though, it's an ethical, moral question about our responsibility to feed the individuals who can. And I know that some people have a deep-rooted belief or feel that they can't withhold that. I think that's well-grounded. I think many people say, I don't see a benefit to that person or us as a family, and I see that as appropriate. That's sort of my answer, but I always tell patients, this is the way I see it, and you need to talk about it as a family. And hopefully have time, because it's, as everyone knows, it's the 1 or 2 kids from out of town who are most in favor of doing everything and thinking that the kids in town or the spouse isn't paying attention. So everyone's got to get together. They have to fly into town and see the person. And I think I see that as part of our role. So thank you. Sorry I didn't leave enough time for questions.